Hello and welcome back to another episode of Taking Control of Cancer, the podcast brought to you from the North East London Cancer Alliance. I'm Steve Bland, and in this podcast we try and give you a bit of a how-to guide to help you, your loved ones, your patients overcome common myths, fears and barriers to cancer prevention, diagnosis, treatment and care. In this special double episode, we're on the road again, and I've come back down to St Bartholomew's Hospital and we're going to explore breast screening. Now, every year breast screening helps detect cancer early when we know it's at its most treatable, yet a lot of people still feel unsure, anxious, or even avoid making the appointment. So today we're going to take you through everything you need to know, from what actually happens at an appointment to why it's so important, what the latest facts and figures tell us, and we'll address some of those fears and debunk some myths and misconceptions for you as well. In part one, we'll give you a back to basics guide covering every aspect of the patient journey, from receiving the invite letter to making the appointment, attending and receiving the results. And in part two, we'll look at some of those myths and some of those barriers to attending and what we're doing to overcome those to help increase the uptake. Now, to do all of that, I'm joined by Mansi Tara, who is the Health Promotion Lead, and Claire Mabena, who is the Lead Nurse, both of you here at the North London and Central and East London Breast Screening Service. Hello, both of you. Welcome.
Thank you.
Hi, Steve.
Right, so before we go into the nuts and bolts of the process, let's kind of set the scene a little bit, because I was looking at some stats. In NHS England stats, 70% of women took up their invitation. This is in 23-24, 5.4 percentage point increase on the previous year. 16,677 women had cancers detected as a result of screening. That's 8.5 cases per 1,000 women screened. As I say, before we go into what that actually involves, what the screening actually involves, how much more treatable, how much better are the outcomes for breast cancer if we catch it early, Claire?
So the whole point of breast screening is early detection. We know with early detection it is more treatable successfully, and it means that less aggressive treatments are required when we do detect breast cancer early. Statistically, the aim is by 2028 that we will be detecting 75% of cancers at stage 1 or stage 2, where we know that treatment is effective and the long-term outcomes are better for patients when we pick cancer and we treat it at an early stage. Breast screening doesn't prevent breast cancer. The aim of it is to detect cancer at an earlier stage, like I said, where these treatments are effective and the long-term outcomes are better for our patients and our ladies.
Do we have any idea, Mansi, of just why 30% of women aren't taking up those appointments?
So I think the breast screening uptake, so I think 70% is our acceptable national standard, which is what all the services should aim for. 80% is the recommended. I think London very often falls short of that, and that's a more complex issue. So it's compounded by deprivation. It could be ethnicity, it could be inequalities there. Language could be a barrier. Very often, like awareness on the importance of breast screening within the population as well could be a factor that contributes to people not coming in for their screening appointment. Sometimes they have previous bad experiences or they've heard kind of experiences from others, and they're just scared to come in for their appointment. So a lot of work that the health promotion team does is to see how we can bridge those barriers and reduce those inequalities of access as well for the population.
But that's a huge number of reasons why somebody might not attend an appointment, or you might not know about an appointment, or might not know the importance of an appointment. How do you go about tackling that? Because that feels like a big challenge.
Yeah, so I think for our catchment boroughs, so the two services that we work for oversee 12 boroughs in London, and we use a lot of kind of data-backed softwares to understand where's the most deprivation, and then correlate it to what's the uptake in those areas for breast screening. And then we plan targeted interventions based on what that deprivation factor is, or is it ethnicity that's affecting it. We partner with local community organizations, we partner with primary care, with alliances to then have appropriate interventions in place or support for that population to then have better awareness and access to the screening.
And if somebody doesn't attend an appointment, do you go back and ask them, to try and find out kind of what are the actual reasons that, the reasons that, each individual might give? There might be, a million different ones, but do you actually go in and sort of find those out?
So we have one program that's active right now, which is essentially, it's called the DNA Project. So the women who do not attend, we call them DNA women in our system. For some of the boroughs that we oversee, we are calling the women who have missed their appointment and offering them to book. So I have a dedicated team member in my team who does that. And through that process, we're trying to collect information on what is that kind of barrier that they're facing. Very often, I think it's just choice. They don't want to engage and have that conversation on the phone with us. Sometimes they have other priorities, other health issues that they're focusing on. Sometimes they're too busy, they're at work. So we do offer them kind of solutions for that as well, like out of office hour appointments, weekend appointments as well. So I think the idea is that we can support them in their issue because it's so personal. Everyone could have their own specific issue there. And very often when we are out in the community as well doing events, we end up asking women about those barriers and kind of diving deeper into it so that can inform the work that we do to improve that access.
Okay, Claire, let's go into what the actual appointment involves. Take me through the process from the very start. Actually, I guess maybe we should start with what is it and who's it available to before we go into the process?
The eligible population, so ladies will be invited somewhere between their 50th and their 53rd birthday for their first breast screening appointment. So screening age for breast is between 50 and 70. Those over 70 can self-refer every 3 years. Now, the reason it's targeted specifically at this age group is because that's where the majority of breast cancers are diagnosed. Approximately 80% of breast cancers will be diagnosed within that age range, and that's why breast screening specifically targets that age range. With regard to your invite, you'll generally get it in the post 3 weeks before the appointment date. When you are invited, you will get various text message reminders. Again, there is the opportunity to call up the service and to change the site if it's not convenient for you, and to change the date and the time as well. When you attend for your breast screening appointment, you will always be met by a female member of the team. All mammographers within the screening program are female. They will confirm your details and they will talk you through the process. So the breast screening itself is an X-ray of the breast. During the appointment, 4 images are taken. 2 from each breast, so 1 to the side, 1 coming down for the top, and the mammographer will talk you through the appointment. It means that there is it's basically an X-ray where there is compression of the breast. Now, some ladies do find this uncomfortable and some ladies do find it painful, but the screening mammographer will talk and support you through that process. The appointment itself generally takes about 6 minutes, so it is quite quick. However, those with additional needs, whether it's physical disabilities or learning difficulties, we do have longer appointment times that they can book into. Once your screening mammogram has been completed, you will get your appointment in the post within 3 weeks of that screening appointment. And for every 100 women we screen, 96 will get a routine recall and will get advice on breast awareness and be called back in 3 years' time. 4 will be recalled for a second level assessment where we've seen something on the mammogram during the screening process. Now, this doesn't mean that there's anything wrong. For those 4 individuals that we call back for the second stage assessment, we will be able to reassure and discharge roughly 3 of those, where 1 will go forward and have a biopsy performed. So the process itself, from having your screening appointment through to getting your results letter or getting callback for assessment, is generally 3 weeks following that screening appointment.
Just go back to the age thing. I know that you can't screen everybody, my first wife died from triple negative breast cancer when she was 40, and I understand you can't screen everybody, but have there been any discussions to lower the age? Just anecdotally, you hear Instagram, the kind of cancer community, so many young women being diagnosed with breast cancer, and I'm not saying they would all be kind of cleaned up by the screening process being open to everybody, but have there been any talks nationally, locally, whatever, on lowering that age?
So prior to the pandemic, there was an age extension program. So that age extension program ran for a number of years, and that was where we looked at screening younger ladies and also screening older ladies as well, so both ends of the spectrum. So ladies between the ages of 47 and 50 were screened, and ladies 70 to 73. Now, we're still waiting on the outcome of that research data to let us know whether lowering the screening age will benefit ladies and extending it will benefit ladies. There is also nationally a discussion happening around tailored screening for younger ladies who are not of screening age. And there are various research programs which are collecting data at the moment. And I think that will guide us for the future into a more tailored screening program. We do have our high-risk screening program, which runs alongside our national screening program. Now, our high-risk program is for those who've been identified having a significant family history who will benefit from more frequent screening, those who may have had radiotherapy in relation to other cancers previously who are higher risk of developing breast cancer, and those with genetic mutations who we know statistically are at higher risk. So we do have our high-risk screening program running alongside our national screening program.
Is that for anybody of any age if you...
Yes, if you have
if you have one of those high-risk factors?
Yes. There are also family history clinics, which if you don't fall within the high-risk category, if you fall within the moderate risk category, which are managed locally by the ICBs in the primary care or the local treatment centres. So these family history clinics, if you don't fit into the high-risk category that comes under our national screening programme, your GP can refer you into these family history clinics to be assessed with regard to your level of risk, whether it's low risk, whether it's moderate risk, and then you can be supported and managed accordingly.
If you don't know your family history, will you be contact? Say, my mum's mum died from breast cancer, so my sister, I think, gets quite regularly scanned, even though she's only in her early 40s. But if she didn't know that, would she have to come forward, or would she be contacted?
If she wasn't aware of her family history, then it would be more challenging to assess her level of risk. So her level of risk would probably be deemed as normal population risk. If you don't have a family history, it is quite difficult to do that. But I would say always start off with having a conversation with your GP who knows you, who knows your history, and who will be able to signpost you with regard to having that assessed further.
But that's like another layer of education, isn't it? Because you have to actually understand not just breast cancer, there might be other cancers that might, cause you to have a higher risk factor.
Yeah, so that comes in with our awareness efforts. So when we are talking within the community, we are talking to women about if they are concerned about their higher risk because people in their family or close kin have had breast cancer or other cancers, then it will be about them going to their GP and then having that conversation. And if their GP thinks that they're at a higher risk, they'll further refer them to that clinic, the genomics clinic as well.
We've talked in this podcast a lot of times about the diversity in this part of London and the challenges that brings. Just talking specifically around the cultural, ethnic diversity in this part of London. What are you guys doing? What are the big challenges that you see?
Yeah, so I think, especially in Northeast London and the boroughs that we oversee, they do have a fairly high deprivation and also communities that might not speak English. Communities like, I think with us, with the Somali community that we engaged with, we could have things translated in Somali, but they actually don't read it. So, that's another additional barrier that we discovered through this work. So often what we end up doing is get like a community influencer and then work with them to go through our presentation with that person. And then when we go to the event, they actually deliver it in Somali to and they're hearing from someone, a peer that they have. So I think that has a higher impact as well while we are present there. I think within this region as well, we know the research has shown that Bangladeshi women are the least likely to uptake their screening appointment. And that's a huge population here in Tower Hamlets and around. And I think, again, our efforts are really, we're trying to make it two-pronged. So one is from like primary care, so actually approaching the GPs in the area and encouraging them to contact the women. Because again, research has shown that if you hear from your GP to go for a screening appointment, you're more likely to.
Yeah.
But then also at the same time, engage with those community organizations. And the Alliance actually does a great job of linking us in with them as well. So working with those community organizations and community champions or peer influencers who can go and actually spread that message. So we're having that kind of approach where we're focusing on a region, but through different partners. So hoping that the message gets across as well.
What are the big things that you're hearing from that community, specifically the Bangladeshi community? What are the reasons for not attending?
I think it's a lot of times it's, it won't happen to me or my community.
Yeah.
A lot of times it's, nobody in my family had it. So that's a myth that if you don't have family history, you won't get it. I think it's also not spoken of. So, cancer is not something that some communities speak freely about. There could also be more modest communities that, don't want to talk about breasts or body parts as such within their families. So I think it's a bunch of reasons and different communities have different ones. But then it's about approaching that in a more culturally sensitive way as well.
Claire, going back to the kind of process, if there's nothing of any concern on the scan and you get a letter saying off you go, do you get another scan in the future? What happens going forward then?
So you're recalled every 3 years for your breast screening here in the UK, but it's really important to do your monthly breast checks in that time frame. Screening is the best tool we have, but it's not 100%. Yeah. So if you had your screening mammogram and you've received your routine recall letter in the post, it is still really important that you do your monthly breast checks. If you do find something, the advice is to go and see your GP straight away, because we do have cancers diagnosed between those screening intervals that do develop. So breast awareness is really important. Nobody knows your body better than you. There is no right or wrong way to do it. The main thing is that you're familiar with what your chest, what your breasts feel like, and that you do it at regular intervals. If you're not doing your breast checks at regular intervals, you're not really going to know what's normal for you, and you may not pick up on subtle changes. So I think both for men and women out there, it is really important to be breast aware and to be chest aware, even though you are attending for your screening every 3 years once you're invited over the age of 50.
You mentioned men there. Actually, that's an interesting question, isn't it? Because I'm presuming there's no screening for male breast cancer. No,
there isn't any screening for male breast cancer. Here in the UK, we diagnose about 400 men annually with breast cancer. And one of the interesting things with men is because it's often symptomless, and they'll feel a lump, and maybe because of embarrassment, they'll actually ignore it. And sometimes what is happening is we're finding that men are presenting later with their breast cancer and undergoing, obviously, more radical treatments as a result to treat it. So again, it is really important that men are chest aware as well. And the symptoms are the very same as with women. And it is, once you see, if you've got a change in your chest area, it is really important that men go and see their GP as well. And I think there is sometimes a lot of embarrassment around that, which can be challenging to get men. But I think it is really important for, the people in their lives, if they do become aware of a change, to encourage and support them to attend their GP to get that further investigated. Again, there are lots of benign conditions. Just because you have a breast change or a chest change, it doesn't mean that this is a breast cancer potentially. There are lots of benign reasons why we develop changes in our chest, in our breast, but it's really important to get those checked out and investigated so you can be reassured.
When you're go on,
I
sorry.
just wanted to add something on the 3-year screening. So we recommend that women attend every 3 years, because the additional thing that we do is we compare their films. So let's say I went for screening today, and then in 3 years I went again. My x-rays from the 3 years will be compared to today. And so we're able to find changes that are very, very small. And again, the earlier we catch it, the easier it is to treat. So as we progress, we do compare those to your previous x-rays to catch them early.
Do you find some people that maybe have a clear scan and then they think, oh, that's me done, and then the drop off is higher, for the 3-year scan and later?
I think statistically, if a lady attends her first screen, she is more likely to actually attend further screens.
Right.
Unless she has a painful experience.
Yeah. So
Yeah.
we do find it's more likely she will attend, but it's getting people through that door for that first appointment. If we can do that and they have a good experience, then the likelihood is they'll continue to attend every 3, every 6, every 9 years.
Do you... Just going back to men, and I'm thinking of my own experience. Do you? I was obviously very aware of breast cancer. I knew, a lump was something to look out for. And I can remember my first wife Rachel calling me into the bedroom, and she said she'd been feeling around, and she said, "Have a feel of this, and what do you think?" And I can remember feeling it, and I knew, like I said, I knew that it was. A lump was something to look out for, but I wouldn't have known anything beyond that. I didn't know what a lump would feel like. What kind of lump it might be, if what I was feeling was even a lump, or if it was something something that should naturally be there. Do you do any education with other halves to help us be a bit less useless?
Well, I think going back to your first point, so there are a range of symptoms that you can look out for. It's not just a lump.
Yeah.
There could be change in skin texture. It could be, nipple crusting. It could be a change in the direction, shape, or size. For men or women, it could be an orange peel appearance, sores, lumps. But beyond that, it could be any change from normal. So that's why when we say that people should practice breast or chest awareness monthly, it's because you get to know your body. And then if there is a change from normal, that's when you go to your GP. I think when we're out and about in the community, we do kind of keep the messaging pretty not very specific to women unless we're talking to a group of women, because we do want men to know that they need to practice chest awareness as well. It's funny because sometimes when we're out in the community, women would come and be like, oh yeah, my man checks it. And then we're like, great.
But I'm sure that's, sure that happens though. And I think, we don't necessarily know what we're doing.
Yeah.
How do we, we'll get onto some of the myths and misconceptions in the second episode of this two-parter, but how do we, kind of shift the dial? Because we're talking 70% now people taking up their screening appointments. The target will be 80, but we'd love it to be 100, wouldn't we? Maybe that's not realistic, but how do we kind of, really start to shift the dial on it?
I think conversations like this one and just getting awareness out there, it is really important. Like you said earlier on, we here in the population that we cover, it is a really diverse community. A lot of this population will come from countries where healthcare isn't free. So again, it's about breaking down those barriers and ensuring people are aware that this is something you are entitled to. Also in relation to the fact that our workforce are female. There are some misconceptions there where they think they're going to be screened by a male mammographer. We don't have male mammographers here in the UK. And then it's also about the language barriers. We have all of our screening sites have access to translation services. to support with people attending their appointments. And I think people being aware of the reasonable adjustments we can make during their screening appointment if they do need longer time because they have a physical disability or because, say, they're disabled, they're in a wheelchair. We do have reasonable adjustments we put in place. Our staff are trained to support people who have a disability, attend and support them have their breast screening. And just for those, other populations, people experiencing homelessness, we again support these people. We do education and training with primary care in relation to how we can support people experiencing homelessness, attend for their breast screening, and support them through that process. So I think it's really important that we're out there in the community educating our colleagues across the community that these are the reasonable adjustments we can put in place. These groups, we want to engage with them. We want them attending for their screening because we know the health outcomes specifically in these groups tend to be poorer than with the general population. So I think it's just, again, spreading awareness of the work we're doing like this so that people are aware and people can contact us. They can have a chat with us. Mansi and I love nothing better than being out there in the community talking through what we can do and support them. And it's not just about us dipping in once, it's about us going back again and building those relationships over a period of time within these communities as well. And I think that will help us further break down the barriers and get better uptake with these lower uptake areas.
And I also think that hearing from your peers is very powerful. So whether it's like, the South Asian community or the Somali community, if someone's coming and speaking to you who you kind of look up to, I think that has a huge effect. And just thinking of one example from one of we have a project on improving the uptake for breast screening within people with learning disabilities. And that's been pretty successful because we've done it in a very structured way, partnering with the Borough LD teams. And we had a pre-visit for these two ladies, which is essentially they can just come and have a look at the facility, meet the mammographer, and if they wish to get screened on the day, they can. If they don't, then that's fine. The pressure's off. And one of the ladies went in and, I think she was feeling comfortable, so she went ahead and got screened. And when she came out, in the waiting area, there was another lady with learning disability, and she heard this one speak positively about it to her carer, saying, oh, that wasn't so bad. And the moment she heard that, she was a bit nervous, but she just went in and got screened as well because she heard it from her peer.
Yeah.
So I think that's very powerful. And we try to kind of do that by exactly what Claire said, going into the community, engaging community champions. We do trainings for that as well with local, charity organizations or kind of borough councils. So yeah, I think that's one way that we really do want to engage more.
Do you find that quite a common reaction when people come out and go, actually, that wasn't anything like as bad as I thought?
Yeah, so it's so different because I think, one, our bodies are different, and then our pain threshold's different, our outlook's different. So some women say that, oh, it doesn't feel like anything. Some women say it's a little uncomfortable. Some say it's very painful. Yeah. So I think it's dependent on a lot of factors of how your tissue is, maybe how old you are. I think all those things also affect your kind of experience. So I think the ones who've had a good experience, they'll keep coming back. The ones who've possibly had pain, we do meet them in the community and they're like, oh, I had it and it was so painful. And I think when we try to engage with them, we try to maybe emphasize that, look, it's a few seconds of, discomfort. But then if you do find something, your outcomes are going to be so much
What a payoff
better.
For that few seconds.
Yes. So it's 6 minutes. Your appointment's 6 minutes.
Yeah.
So in the longer, in long-term outcomes, it's like not that bad. So I think we do try to kind of share that message with them and, of course, emphasize breast awareness if they're not coming in for screening.
That's such an interesting point, Claire, isn't it? Like, we're all so different in the way we handle pain. I can remember before Rachel started her treatment, she wanted to explore the scalp cooling cold cap. She was very very proud of her hair and she wanted to do everything she could to try and save it. And she said, oh, I've heard all these terrible stories, people in absolute agony, when they're using the scalp cooling. And she tried it for the first time and was like, I didn't feel one bit of pain. I didn't feel anything. And then there was a lady next to us in the next chair who had the cold cap on, and she was literally bent over double the whole appointment, just moaning and screaming, because she was in so much pain. There's such a difference, isn't there, in terms of how our body reacts to these things?
It is, and I think the thing to be aware of as well is if you have had an experience where you found your screening mammograms painful, speak to your mammographer. They will support you with regard to getting through the appointment, with regard to the level of compression that they use. So I think if you've had a bad experience, it's really important that you talk with your mammographer during your next appointment so they can support you as best they can with regard to the screening process and being able to tolerate the discomfort that can sometimes arise as a result of it.
Is breast density a big factor in these early screening appointments, either of you?
So with regard to breast density, that's something that's been looked at from a research perspective. With denser breasts, they have less fatty tissue, so the breast tissue is harder to assess and harder to see. So with ladies with denser breast, it can be more challenging from a screening perspective. There have been some clinical trials that are looking at breast density in relation to breast screening and their risk. And looking to the future, maybe breast screening will look different for these ladies. This is a national conversation that's happening, and a more tailored approach with maybe different technology to the future for ladies with denser breasts. But yes, it is more challenging to assess the imaging on these ladies.
Because that was something that in our case with Rachel, she apparently had very dense breast tissue, which is something we didn't know about. And then she started going for the scans when after she found the lump, and there was some ambiguity in what they were seeing. They weren't really quite sure what was going on quite a lot of the time, and they sort of brought this term up, breast density, that we'd never heard of as being a factor. And I wonder if, like you say, in 10, 15 years they might have a different way of doing it for people who have dense breast tissue.
Yeah, and I think with like everything here in the UK, it's research-based. Yeah. So it'll be interesting to see the outcome of these clinical trials that have just concluded in relation to this. But yes, I think you're right. I think in 5-10 years' time, we'll be sitting here having a very different conversation about screening and what we're doing with the advance of technology alongside the clinical research that's ongoing at the moment.
I think that'll do for the first part of this episode. Thank you both of you so much. We'll tune in for the second half. We're going to talk about some myths and misconceptions. We're going to do some myth busting and carry on with all you need to know about breast screening.